at the webinar last week, the rigorous guideline development process. There you can see the 7-step process that we use. And from that, we move to the next circle, moving down counterclockwise to deployment and implementation. There you can see a number of the strategies, again, that we will be talking about today, including our spotlights, champions, clinical fellowships, with our communities of practice, and nursing order sets. From there, moving on to the next color circle, you'll see a focus on evaluation, monitoring, and sustainability. Here's where areas that discuss outcome indicators, quality improvement, and NQuire, which is nursing quality indicators for reporting and evaluation. And future webinar, we'll be discussing evaluation more in depth and feature aspects of NQuire. All of our work is really focused on better health outcomes, better outcomes for patients, for organizations, and for systems. Just to look at the goals of the program, basically the goals all direct, as I said, to better health outcomes or improving health care. One of the big areas of focus with best practice guidelines is to reduce the variation in care. We know varied care, lack of consistency in care programs does in fact cause additional costs as well as reduce the ability to meet outcomes. In addition, we're looking at transferring research evidence into practice as an outcome, conveying the knowledge base of nursing, assisting with clinical decision making. In fact, many of the tools enable us to do that, identifying gaps in research, and you'll see this in each of the guidelines, stopping interventions that have little effect or cause harm. This is one of the strong outcomes of evidence-based practices, to identify as well interventions that have been based on tradition that we find do not work. And lastly, reducing cost. We know from the evidence that we have amassed with this work that evidence-based care is cost-effective care. I'll move on and just talk about our next speaker is Dr. Monique Lloyd, and she's going to review just briefly the assessment and management of foot ulcers for people with diabetes best practice guidelines. It's a very brief overview, and on the slide you can see also the URL that will take you to the archive presentation from March 19th. So go ahead, Monique.
Great, thank you, Imogene. As we mentioned, this is Monique Lloyd speaking, and what I wanted to do is alert you to the assessment and management of foot ulcers for people with diabetes guideline, for which this presentation has been adapted for. That particular guideline is now in its 2nd edition, which we released on March the 19th, that's last week, and we did have, for those of you who were unable to attend, a presentation similar to this on the particulars of that guideline, including the practice recommendations, the education recommendations, and the organization and policy recommendations. That presentation is archived, and you'll be able to find that following this particular presentation on our website. Now, the link on this particular slide is quite lengthy, but if you visit rnao.ca/BPG, you'll be certain to find the foot ulcers guideline, and you'll be able to find the WebEx presentation archive there, as well as this presentation. What I'd also like to do is take a moment to say that we will provide a moment for question and answers following this presentation, and feel free, as you have questions, to type them into your chat boxes in the WebEx platform, and we do have been sure to address them following our presentation. So I'd like to introduce you to the guideline development team. So each of our RNAO best practice guidelines is led by a process manager in very, very close collaboration and support from an expert panel that's based on their expertise and relevance in the topic area. For the foot ulcers for people with diabetes guideline, our panel was led by the expertise of Laura Teague. You'll see there a list of other expert panel members, all of whom details are available in the guidelines. In terms of RNAO staff, the work was led by Dr. Imogene Knock, as well as myself, and Risha Nazarali, who was the program manager involved in overseeing all of the work. While a team of very involved nursing research associates and research assistants led the systematic review process on which all of the evidence presented in the recommendations was based. As we're in the process of developing our guidelines, once we have the penultimate draft of that guideline, we send it out for stakeholder review. Again, soliciting the individuals with expertise and relevance in the topic area to provide their feedback on the recommendations and the guideline, and from that we're able to address any concerns, any gaps, and revise the final product. And we thank everyone who assisted in that process. Again, details of those stakeholder reviews are available in the guideline itself. In terms of the purpose and scope of this guideline, the guideline was developed to address the question of how to assess and manage people with established diagnoses of diabetic foot ulcers. So it's important to note that the guideline is relevant to all nurses and the interprofessional team who provide health care across all settings to people who are 15 years of age and older with type 1 and or type 2 diabetes, and importantly to note, who have established diabetic foot ulcers. So it focuses on the assessment and management of foot ulcers in people with diabetes and also risk of re-ulceration in those individuals. In the research questions that formulated our systematic review for those recommendations, we focused on 4 areas. The first, the most effective methods for the assessment of foot ulcer in clients with diabetes. The second, management of foot ulcers, and as I mentioned a moment ago, prevention of re-ulceration in clients with diabetes. So examined healthcare professional education and training that is required to provide effective care for those individuals, and well, organization and policy level evidence around effective assessment and management of foot ulcers in clients with diabetes. The guide itself is comprised of 19 practice recommendations, and those recommendations are broken up into areas of assessment, implementation, and evaluation. And as well, we include 2 recommendations on education, as well as 5 recommendations around organization and policy supports required for effective assessment and management of foot ulcers in clients with diabetes. What I'd like to do now is introduce to you Heather McConnell, the Associate Director for Guideline Implementation and Knowledge Transfer at RNAO, who will continue on with the remainder of this presentation.
Hello, and thank you for the opportunity to speak with you this afternoon. It's my pleasure to have the opportunity to introduce to you RNAO's framework for guideline implementation. And this framework is truly described in our Toolkit, Implementation of Clinical Practice Guidelines, in its 2nd edition, which is a evidence-based guide for a systematic approach to guideline implementation. It is available for free download on our website. You'll note the address there, and is available in English and French. This document has been widely accessed over the years. We sold tons of copies, and downloads have exceeded many thousands. We support not only implementation of practice guidelines, but also any practice innovation where a plan change approach is required. And we've certainly received much feedback from the nursing community and the healthcare community that this has been a very valuable resource in able to support the implementation of best practice guidelines. We're first evaluating the implementation of our original guidelines about 2 years ago. Nurses who were leading the implementation across a range of practice settings indicated they needed a guide for supporting practice change in a structured, planned approach. They needed some direction on being able to know where to start and what some of the critical elements they needed to consider throughout the implementation process. And based on that feedback, we developed the toolkit to meet their objectives in terms of helping them support enhanced outcomes for clients through the impact of the practice guidelines. So the goals of the toolkit are to help those responsible for guideline implementation identify important factors in their organizations that influence the adoption process, to gain the support of key stakeholders and champions, and to assess organizational support and readiness to adopt practice change. And as I mentioned, was originally developed a number of years ago in 2002, and the second edition was released in September 2012. And throughout this revision, we were able to incorporate an interprofessional panel of researchers and practitioners who knew the evidence that supported the development of the toolkit that was identified from systematic reviews, price studies, and the expert opinion of panel members. We were also very much able to engage and incorporate through the revision process feedback from our many networks of those implementing the guidelines in terms of what was useful to them, some critical examples of successful strategies, and the inclusion of an external stakeholder review process. What resulted from this work is a toolkit that has really been designed to be a practical approach to guideline implementation. We have utilized a case study approach throughout that reflects examples from a variety of different practice settings. We've included sample templates and blank templates for ease of use so that you can utilize them to create your own documentation for your implementation process. We have incorporated within this vision the incorporation of tool-related resources and examples in each chapter based on the experiences of those who have implemented RNAO's BPGs and incorporated these 10 years of implementation experience since the last publication from the acute care sector, public health, home health care, and long-term care. One of the other critical components that reflect this RISE toolkit is an evidence-based approach using the adaptation of the research to action model and a step-by-step guide to guideline implementation with a very significant focus on sustainability. So this is a reflection of the adapted knowledge to action framework that we've used to guide the development of our toolkit. Its step of its model has been incorporated into it, and this walks you through slowly throughout the process. The center of the model is really the knowledge creation elements, and this is really looking at knowledge inquiry, knowledge synthesis, and knowledge implementation of best practice guidelines. And what we'll do now is we'll walk you through the action cycle around the circumference of the model that really reflects the elements of the various different chapters of the toolkit. So this chapter of the toolkit is identifying the problem, reviewing, and selecting the knowledge. And this is the first phase of the action cycle. This is where clinicians and managers define a problem, often through their quality improvement methods and analysis of indicator data, and then identify and review possible best practices that may help to resolve the problem. This may, in your case, if you're considering the implementation of the diabetic foot ulcer guideline, monitoring indicators related to client populations with diabetic foot ulcers, your healing amputation rates, etc. And then once this is done, clinicians and managers have identified a clinical guide to implement, such as the diabetic foot ulcer best practice line. They do best practices and determine if a change is actually necessary. And this, of course, is a gap analysis. And in the toolkit itself, there's an excellent example of a completed gap analysis that can help you in considering the approaches you might take to addressing this with your closest. Chapter A is a focus on adapting the knowledge to the local context. And this whole section is really about understanding of the local context and the implications of introducing the best practices within the context so that recommendations can be adopted in ways that are suited for the individual organizational culture. In this section, there's the opportunity to also identify guidelines through the use of the AGREE tool, the appraisal guidelines for research and evaluation, which is an internationally recognized tool that helps to support the development of best practice guidelines. And again, this is really critical that all the stakeholders involved have the opportunity to participate in this process so they can understand the quality of the evidence and the specific focus they're going to take on addressing the critical issues related to those clients with diabetic foot ulcers. After Chapter 2B, again, focusing on the local context, is around stakeholder identification, analysis, and engagement. And this is absolutely critical to ensure successful implementation. throughout this process, the first step of this, of course, is identifying the broadest range of stakeholders possible that are going to be impacted by your implementation efforts. And certainly within the context of the diabetic foot ulcer guideline, this may include your existing wound care teams, external wound care consultants that you might utilize throughout your community, members of the interprofessional team, patients, their families, supply companies that provide products to stakeholder influence and support for guideline implementation. And again, the thought here is to just advise who's going to be able to support you in your work, who might address attention to your work, and who may in fact be rather neutral to the implementation strategies you're going to be moving forward in relationship to guideline implementation. Resources are absolutely critical to be able to move forward with successful practice change, and this particular chapter really focuses on the assessment and acquisition of resources required to execute the plan activities. It's important to understand the availability of resources in the local context, and it's important to be able to recognize where your stakeholders can help you in accessing those resources and making them available to your implementation team. Through this chapter, there are examples of assessment sheets and suggested resources for each step in the toolkit that might have an impact on the resources available within your organizations. The chapter focuses on assessing facilitators and barriers to knowledge use. And again, there are a number of assessment tools provided within the guideline implementation toolkit, to help support you within this work, as well as potential strategies to assist with implementation, to address the barriers that you have identified within your organizations, but also leverage the facilitators to accessibly address the findings that you've identified through your stakeholder analysis and your resource review. 4 is a critical chapter focusing on selecting and tailoring implementation interventions and strategies. And again, recognizing that it needs to reflect those choices that you make in terms of implementation, need to reflect the stakeholders that you've explored, the existing resources that you have, your barriers and your facilitators. All of those things will impact on the decisions you make about the implementation strategies, as well as, of course, that support specific strategies over others. The action plan needs to draw on this data to identify and support the selection and tailored interventions that will facilitate guidelines. Chapter focuses on monitoring knowledge and evaluating outcomes. This really focuses on 2 phases of that are related into determining whether implementation interventions have been effective and including uptake of the recommendations, whether there have been an impact. So the 2 phases are monitoring the actual adoption of the new knowledge including adherence to the guideline recommendations or the clinical practice changes, and also evaluating the outcome resulting from implementing the best practices. And of course, throughout the toolkit, we focus on process, outcome, and structure indicators, as well as opportunities and examples of things you might want to consider in terms of how you might measure those outcomes. The chapter is focusing on sustaining knowledge use. And again, as I mentioned earlier, this is a new area for us in terms of this particular toolkit. The definition of sustainability from Rogers is a degree to which an innovation continues to be used after the initial efforts to secure its adoption are completed. And certainly this particular chapter really focuses on a number of different strategies to help you plan for the long-term improvement of patient care outcomes and the delivery of healthcare services based on effective implementation of guidelines. We use the National Health Services Sustainability Model to help guide some of the self-assessment that you'll need to do in terms of sustainability. And of course, this particular model includes the intersection of staff, process, and organizational elements. We've discovered by working with a large number of organizations over the years that sustainability is absolutely critical to long-term success, of course, and that you really do need to start thinking about integrating sustainable processes into your practice change and efforts very early in the process. At this point, I'm going to move away from the toolkit and talk a little bit about some of the very specific implementation strategies, and I'll have some of my colleagues join us over the several minutes to talk about these specifically. But one of the things that we identified finding with organizations and individual nurses over the last many years of this particular program is that we do really need to address implementation at multiple levels and in multiple ways. And so we're going to speak to implementation strategies that we found to be successful at the individual, organizational, and system level. Some of the individual strategies that we found particularly effective are our Nursing Best Practice Champions Network, our Learning Institutes, and nursing order sets. And I'll speak to the first two of these strategies, and then I'll turn to my colleague Rita Wilson to speak about nursing order sets. Now, the RNAO Best Practice Champions Network has been in place since 2003, and it was really developed as a strategy to help support the uptake, promote and support the uptake of best practice guidelines in nursing practice. We started with a very small group of re-engaged individuals who really gave us a lot of feedback on what would help them to be successful in their organizations in implementation of best practice guidelines. And over the years, we have grown this program substantially, not only in the province of Ontario, but across the country. We see that we've had participation across the continuum from all healthcare professionals, not exclusively nurses, but also in a range of roles within nursing practice and within practice settings. Frontline practitioners that are champions, we have senior leaders that are champions, we have academic and faculty that are best practice champions, all working together to help support the uptake of evidence in practice. Within this group, there's a wide type of activities that they actually participate in to support practice change within their workplaces. And these may include raising awareness, could include education to other staff members. Many of our best practice champions are actually leaders in guideline implementation teams. So their involvement varies widely, but their focus on evidence-based practice is a consistent one. Throughout this initiative, we also have opportunities for those champions to stay connected through a variety of different means, including ongoing webinars and teleconferences for professional development purposes, as well as online communities of practice to support them in their work. The preparation that we provide to the champions is an orientation workshop that really focuses on not just the clinical content of guidelines that they might be implementing, but rather on the process. They're focused on the model that I just discussed in the implementation toolkit. So nurses who participate in the Champions Network are really able to transfer that knowledge that they've gained about guideline implementation to many different situations and guides that they might be implementing within organizations. So it's focused on the process, not necessarily on the clinical content. We have champions, best practice champions, and then we have champions in very specific sectors or within specific projects that we're working on here at the RNAO. And we found again that this is an extremely effective strategy for knowledge translation and knowledge transfer. Now to our learning institutes, and this is an approach that we have taken to professional development for nurses and other health professionals to enable uptake of knowledge and skills in key areas related to guideline implementation. Now, the unique thing about the institutes are that they are usually about 3 to 5 days long of very intensive educational offerings that will include an integrated curriculum that focuses on theory, application, and small group work. Very much focused on networking and developing networks of support through the institutes to really help support ongoing work that nurses and others are doing in guideline implementation and evidence-based practice. And you'll notice that the topic areas that we have available for these institutes include things such as wound care, chronic disease prevention and management, primary care, guideline implementation. In fact, for that institute, we have a foundational stream that really focuses on the content that I've just reviewed in the implementation toolkit, and an advanced stream for those who have either participated in the institute in the past or have extensive experience in implementation to really have the opportunity to come together and problem solve some of the issues that they're addressing and gain expertise from others who've successfully implemented, evaluated, and sustained guidelines over time. We also have an institute focusing on healthy work environments and one focusing on mental health and addiction. So you can see some of these relate to the clinical guidelines and the healthy work environment guidelines that we have available with a much focus on support for uptake. Of their interest for the diabetic foot ulcer guideline is a learning institute called Best Practices in Wound Care, Minding the Gap. And the goals of this particular institute are to enhance leadership in wound care guideline implementation and evaluation, review and clarify specific guideline recommendations through didactic, case study, and skill-based labs. And the focus for this institute is on 5 of our best practice guidelines: risk assessment and prevention of pressure ulcers, assessment management of stage 1 to 4 pressure ulcers, assessment management of foot ulcers for people with diabetes, which of course is the focus of this discussion today, prevention of foot ulcer complications in persons with diabetes, and assessment and management of venous leg ulcers. The whole focus of this is to provide mentorship regarding the development of business program planning, research, policy, and surveillance in all sectors of healthcare related to wound care, and facilitation of innovation, allowing each individual participant to develop an initial plan for future successful implementation of best practice guidelines in their workplace. And the next offering of this particular institute will be March 2nd to 7th in 2014 here in Ontario. So I'm going to turn the discussion over to my colleague Rita Wilson, and she's going to share with us the implementation strategies related to nursing order sets. Rita.
If we're not able to link Rita, Monique Lloyd can start this session, and then when Rita links, and we'll turn things over to her. So, Monique.
Okay, thank you, Irma-Jean. So the RNAO is very excited to be able to share with you a relatively new strategy for us in terms of operationalizing nursing order sets for each of our best practice guidelines. And order sets are an individual and organizational strategy using technology to support nurses in implementing evidence-based interventions and reduce the variability in care. And I'll share with you a more specific definition of order sets in a moment, but I wanted to show in terms of the knowledge to action cycle by Ian Graham, where we've envisioned nursing order sets to be of assistance for organizations. So nursing order sets do sit in that inner triangle as a knowledge tool or product that can assist in integrating the best practice guidelines and in particular the practice recommendations into electronically enabled clinical systems, but as well in paper-based formats. And really adapt the practice recommendations or that knowledge contained in the guidelines to the local context, again in clinical pathways, care plans, or paper or electronic systems, as I mentioned. You'll Irma-Jean, if you could go back one slide, you'll see there that we have 27 nursing order sets developed, and it is the intent to develop nursing order sets for each of our clinical best practice guidelines. And again, just to note that RNAO does have healthy work environment guidelines as well, but our order sets are really targeted to our clinical guidelines. In terms of the full definition of nursing order sets, our includes a group of evidence-based interventions that are specific to the domain of nursing, and in particular they're ordered independently by nurses, and that is without a physician's signature, to stand the care provided for a specific clinical condition. And in this particular case, of course, we're speaking about foot ulcers and clients with diabetes. An order set, again, takes the evidence-based practice recommendations in a clinical guideline and standardizes them using clear, concise, evidence-based nursing interventions, again, derived from the practice recommendations or guidelines, and aligns them with the nursing process. Each individual order set or order within the order set is linked to the practice recommendation to which it relates. And you'll see there the highlighted red bar indicates the practice recommendation number directly from the guideline. And I should stop for a moment and just let you know that what you're looking at on your screen right now is in fact an example of the Assessment and Management Foot Ulcers Nursing Order Set and what this would look like either in paper format or electronically integrated into a clinical information system. Continuing on, the order set highlights the interventions with the strongest level of evidence. And I'm sure if you can read that on your screen on your computers, but it does state in the order set that the interventions displayed in bold font are supported by the strongest evidence. And in the guidance itself, we do discuss how we grade the strength of the evidence in each of the recommendations. There are links to associated documents and decision support resources. And what we find is extremely integral to assisting clinicians in their practice, and that is directly linking each of the individual orders, again, obtained from the practice recommendations in the guidelines, to associated documents and decision support materials that can assist the practitioner in making evidence-based practice decisions and as well finding the evidence that supports those particular orders. Each intervention is formulated as well using standardized terminology. And in respect to the standardized terminology, RNAO is also extremely excited that we've recently been accredited as an ICN, so an International Council of Nurses, INP Research and Development Center. And ICNP, of course, is a nursing terminology being utilized and promoted, adopted, and endorsed globally as the standardized terminology for nursing language. So each of these particular orders in the order set are being coded to ICNP terminology, and we're extremely excited about the opportunity this will provide in order to link common interventions across different areas of practice for measurement and benchmarking. In terms of nursing order sets, we do know that electronic medical records or electronic health records or electronic patient records are now central to care to Canada and in particular around the world. Standardized nursing data is essential, as I mentioned earlier, to facilitate the seamless exchange of health information, comparative analysis, and research. And again, the RNAO ICNP R&D Center allows RNAO to collaborate with nurses from ICN and other ICNP R&D centers to map nursing order sets to ICNP. Now, I believe there are 10 such accredited centers across the globe. And of course, if you could hear Doris in the background, we're very excited that we're the only one that is in fact pursuing this particular research and development using nursing order sets specifically to our practice recommendations, and we are the only accredited center in Canada. Again, ICNP is a unifying nursing language designed to identify and describe nursing practice and its contributions to health outcomes, and it's recognized in Canada and globally, again, as that standard international reference terminology for nursing. The orders are also being mapped to SNOMED CT, which is the national terminology language adopted by Canada Health Infoway to support health record, or again, EMR, EPR interoperability. So what are the benefits of nursing order sets? And I've alluded to several of those in the previous slides, but really nursing order sets are facilitating technology-enabled best practice guideline implementation and providing evidence-informed decision-making at the point of care. Again, utilizing standardized nursing terminology, and they are a tangible and pragmatic mechanism to embed evidence-based nursing assessments and interventions into clinical systems. I will emphasize here that they're not only electronically enabled, but of course are also a benefit for organizations and paper-based systems. They link nursing-sensitive outcomes to specific nursing interventions and provide data analytics to evaluate outcomes and inform practice. And in particular, if the order set is embedded electronically, there is that ability to capture the analytics from BPG orders as a nurse initiates each of those processes. It provides NQuire data collection for process indicators, and NQuire, again, is nursing quality indicators for reporting and evaluation, which is an RNAO initiative to develop quality indicators based on the practice recommendations in each of our guidelines. Again, with electronically enabled nursing order set, initiation any of the orders within that order set can also serve as a data capture tool for those orders that link directly to some of those quality indicators. It is patient safety and quality of nursing care, again through the standardization process and the link to evidence-informed, evidence-based recommendations, and strengthens interprofessional care. What I'd like to do now is allow Ermagine Baynock to continue on with the presentation with our next organizational level strategy.
Very much, Monique. And I would say perhaps at the question period, Rita, if you're able to tune in then, we can hear any other comments from you or have you join in answering questions. I'm looking now to talk about the organizational strategies. Have talked about the individual, organizational, and system strategies. The organizational strategies really are designed to influence the uptake of guidelines across healthcare organizations so that they enable practice excellence and, of course, positive client outcomes. This really, as a strategy, is really meant to augment the work of a number of individual nurses and champions who also bring on board their knowledge and skills and passion. Our key strategy is called the BPSO, the Practice Spotlight Organization. And I'll tell you a little bit about that in the next few minutes. You can see here the number of logos that represent the spread of the BPSO designation around the world, and I'll talk more about that as well. Our best practice spotlight organizations and are organizations that partner with RNAO to implement multiple clinical practice guidelines over a 3-year period. During this period, they receive support as well as additional knowledge and resources in order to be successful in implementation. You heard Heather talk a lot about the implementation toolkit, the variety of steps. What happens with a spotlight organization is they develop a clear practice change methodology in their organization. That each time they implement a guideline, each time they implement practice change, they are using a methodology that they have worked on as an organization. So within RNAO, in order to become a BPSO, there's an application process as well as a formal partnership with RNAO through BPSO agreement. Now, there are very specific requirements. We're looking for use of a systematic approach to CPG implementation that involves an infrastructure, reporting requirements, contributions to knowledge exchange sessions, sustainability planning, and measuring outcomes through the use of standard indicators. And with our BPSOs, they're actively involved and inquire. They're interested and committed to sustained use, expansion, and spread. So our BPSO designates must commit to sustained use, expansion, and spread, and be engaged in mentoring opportunities. In Canada and around the world, we currently have 68 BPSOs with 298 individual sites across Canada and internationally. You can see there on the slide the number of BPSOs we have. We started our BPSO in 2003. Every 3 years, we bring in a new cohort. In 2012, we introduced our latest cohort of 15 BPSOs. This includes a number of different organizations from across all sectors, but our first family health team, our first nurse practitioner-led clinic, and then Ontario Telemedicine Network, which is certainly an organization that blends both practice and education in its work. Our international BPSOs consist of 2 BPSO country hosts, one in Spain with 8 sites and one in Australia with 3 sites. Our BPSO hosts act like an RNAO in their country as they support BPSOs through every region. The hosts work closely with us on a regular basis in order to make sure that the support, the processes, our evidence-based methodology is used throughout. Has 2 BPSOs, Colombia 2 BPSOs, and the USA one. In terms of how we know this works, you can see from this slide that we have seen through BPSOs, thousands of nurses and other healthcare professionals have become involved in evidence-based care, and this work has impacted the care of over 1 million patients around the world. I won't go into the BPGs that have the greatest impact on patient and on practice outcomes, but you can see that, and you can see how organizations have worked to sustain their implementation and outcome strategies. I wanted to spend a few moments on system-level strategies. We not only then are focused on organizations and individuals, but as well want to influence entire systems so that we look at ways that we can influence policy, ways that we can spread this work beyond our borders. There are a number of provincial projects that use RNAO best practice guidelines, the smoking cessation guideline, the falls guideline, the number of mental health guidelines that we have. And in subsequent webinars, we can drill down in relation to some of these areas. Nationally as well, we have a number of strategies that take this work out across our country. We have a national smoking cessation project, also a focus in long-term care with Canadian Patient Safety Institute, partner with not only Health Canada for smoking, but Human Resources Skills Development Canada for elder abuse, and lastly are working with First Nations in relation to our chronic disease and mental health best practice guidelines. Internationally as well, we have same processes that we use working through our hosts, so that we have champions around the world, and as well the slides for the future will include information from our international BPSOs as they look to develop not only individual strategies, but countrywide and other international strategies. I want to turn things now over to Karen Ray, and we're delighted to have Karen with us from St. Elizabeth Healthcare. And St. Elizabeth Healthcare is a pioneer BPSO that joined our BPSO program in 2003. And Karen will provide information in relation to the work they've done in implementing the diabetic foot ulcer in St. Elizabeth Healthcare. Karen, are you on?
I am. And thank you very much.
Karen, we're having some trouble hearing.
Let me turn the sound up a little bit then. Is that any better? Better? Is better?
This is better.
Okay, how about that?
Yes, if you can speak louder and maybe closer to your mic. Thank you.
Okay. How does that? Is that better?
Yes, thank you.
Okay. All right. Well, thank you for the introduction. One on the line. As Imogene said, my name is Karen Ray, and I work for St. Elizabeth Healthcare. We have been a BPSO since 2003 and have implemented the diabetic foot ulcer guideline. Diabetic foot ulcers are commonly seen in the home care environment. They are considered a chronic wound, and people struggle to heal them over a long period of time. So we have done within organization is use a lot of the strategies that Imogene has already and Heather have identified. So for those of you who don't know St. Elizabeth, we actually are a home health community organization in Ontario. We employ over 6,500 professionals, and we have service delivery centers across Ontario and beyond. In addition to the assessment and management of foot ulcers for people with diabetes, we also, I'm not the focus of this presentation, but we also have implemented the reduced foot complications for people with diabetes in association with the other guidelines. As Ermine and Heather alluded to, there are another number of strategies that we have used, and one of the strategies that has been particularly helpful in our environment is the use of the Champions Network. And for us, being a home health organization, our frontline staff in the home with clients and their families. So we needed to look for a method where we could get the knowledge from the corporate office out to the frontline staff. And so how we've gone about doing that is having a complete and comprehensive champion network, which includes not only our clinical consultants, which are like advanced practice nurses and educators, but at the local level we also have what we call K2P nurses, or knowledge to practice nurses, who work with the frontline staff. Plus we also have clinical resource nurses. And then at the front line, we have nurses that take on primary responsibilities for their clients with diabetic foot ulcers, and again, work with the K2P nurses when healing doesn't seem to be taking place in a timely way. So that has certainly been a very good strategy for us to help get evidence right to the point of care. Heather talked a lot about the implementation toolkit, and I really would highly recommend the use of this toolkit. The second edition has been revised to include several areas that we felt were missing, specifically around change management, and also, as Heather said, around sustainability, because implementation and sustainability strategies need to be developed in tandem as you're planning out your project. So we certainly have used this toolkit. It really helps to identify not only your population, but helps you do your gap analysis to identify your stakeholders, the barriers, and so choose some effective implementation and knowledge transfer strategies, and then look at how you're actually going to monitor and get the information out of your healthcare system to see whether you're actually doing a good job or not. The thing that we've done at St. Elizabeth, we've embedded the guidelines right in our program structure. So the advanced practice nurse for wound care is the one that really leads the implementation of these guidelines. So it's not me as the BPSO leader, but it really is coming from a clinical and operational focus. We also have a number of clinical decision support tools that, again, there are some examples in the toolkit, but things like helping people make decisions at the point of care. We have client education materials, we have assessment tools, so all those things that are really useful for staff to help put the evidence into practice. The other thing that we've done is we've tried to ensure that the guidelines are embedded in not only the clinical care that we're delivering at the bedside, but also all the other supporting mechanisms. So in our new higher orientation, we also include the use of guidelines. We talked about the use of champions. Audit and feedback is an area that we're really working on now. We're really working on the idea of trying to get the outcomes back to the bedside nurses so that they're able to see how they're doing. And lastly, I'll just mention that we're involving our leadership teams more and more because it's been shown that they can be quite influential in moving evidence into practice. And lastly, this is about the inquiry and evaluating the outcomes that you're seeing. At St. Elizabeth, we use a report card, and so we are able to look to see if we in fact are making a difference, and if not, we can then mobilize an improvement strategy. And again, giving feedback to not only the point of care nurses, but also the leadership teams so that they understand what kind of activities need to take place. I will turn that over to you.
Thanks, Karen. It was very, very informative, and I want to congratulate you for the success that you've had as a designated BPSO, really with us now for 10 years, and for the work you've done in implementing, I believe it's over 17 best practice guidelines in all of your sites, and really think you've done a marvelous job in enhancing clinical practice in home health care and beyond. So thank you. I want to now, before we have any summary comments from Doris Grinspan, just open now the lines for a few questions. If there are any questions, we probably can take one or two, and then we will have to conclude and close. Any questions now from our listeners out there? You can write your question. While you may be waiting, if you are thinking of questions, I'll call Doris Grinspan to make any final comments, but we certainly will take, I see a question now. Karen Ray mentioned tools that help people make decisions at the bedside. Is she willing to provide her email so we could make contact with her with the possibility of sharing these tools? One of the things I would say in answer to that is that if you do look at the information on our website in relation to our spotlight organizations, we pull together key resources and tools that can be shared. So it's probably a good idea for, if you're interested in any of the RNAO tools, to link back with us. You have our website and our email addresses. I don't know, Karen, if you have any other comments.
I think that there are some tools in both the implementation toolkit and also at the back of the guideline itself. So to Josephine, I would, or the person that asked the question, have a look there, and I think you'll probably find some things that would be useful.
Thank you, Aaron. Are there other questions? No question, but I wanted to thank you all for the excellent presentation. Thank you. And that may be a good note to turn things over to Doris on to wrap up our presentation. Know that you can contact any of us, Andrea Stubbs, and of course, feel free to visit our website. Doris.
Thank you so much, and thank you everybody for the excellent presentation, and for those of you that have questions, you always can write to us. I just wanted to recap a couple of the elements that my colleague spoke that I think could be of interest to you in the go forward. First of all, on the area of, let's start with small, on the area of institutes. We provide the institutes here in Ontario on an ongoing basis. We also provide the institutes upon request anywhere else in the country, and we have done several. Also, we have done internationally, so for those of you that come from our countries to the webinar, by all means, we can organize institutes for you as well. In relationship to the best practice spotlight organizations, the BPSO journey, which, as you heard from Karen from St. Elizabeth and others, is a 10-year journey by now. Now it works both on the issue of uptake of guidelines. We also know it works on the area of outcomes. BPSOs individually have published a lot on tremendous success that they have with practice changes as well as with outcomes in terms of patient organizational outcomes. In relationship to you joining as a BPSO, you can do that whether you are an entity from government. Our colleagues in Spain actually, it is the federal government in Spain that is the BPSO host organization. Or you can join also, of course, if you are an organization. You can join if you are a representative of a union. You can become a BPSO host organization if you are the representative of a professional association. That's our case, etc., etc. In Australia, those that are today participating is in fact the nursing union. Of course, individual organizations, which are the great majority of our BPSOs, can join directly with us. And you will receive at no cost all materials of RNAO. It is not a revenue generating initiative. We share the materials at no cost, and we also train you. For those that are outside of Ontario, you do need to bear the cost of bringing people from here to train you there, or you can send people from your jurisdictions to be trained here. I also want to point to Heather's comment that we are in the second edition of the Toolkit using quite a bit the NHS model. I want to link it to two things. Many organizations and governments today are looking to the NHS model as a model that promotes uptake. But I also want to take you back to the explanation Imagine gave on the side, on the three circles of the BPGs that we shared last time. And is that one aspect that differentiates our BPG's best practice guidelines from any others in the world is that actually we, in addition to providing very robust evidence-based systematic reviews, clinical recommendations, we also provide work environment recommendations and provide educational recommendations. So when we speak about NHS that focuses on processes and organizations, that is in fact the way that we, from the get-go, in 1999, were focusing the development of our BPGs. And one of the reasons we attribute so much success to the BPGs. Part of the success is on the ground up and top down and sideways approach to whole system change, where staff nurses, other direct healthcare providers, and management and care administrators, which is part of the agreement on the BPSO, and unions and professional associations and champions in research join together with governments to move the agenda forward. Given that my last word was on government, let me link it back to the CoF request that we do these webinars and the Council of Federation Initiative on Clinical Practice Guidelines. In that, spend just a second because of time to thank Vasanti Srinivasan, who is ADM here in Ontario, and Louis Dimitrapoulos, who is the right hand for Vasanti, as well as Diane Wilson from Alberta, the ADM Alberta, and her team, the absolutely tremendous work that they have done responding to the premiers and leaders of the territories mandate to actually select and move forward clinical practice guidelines for national implementation. We have been privileged to work with them, as well as to work with the Canadian Nurses Association and Canadian Medical Association and HIL in this initiative that is quite fantastic in terms of learning to work together to move agendas. And in this case, what an important agenda is that it is BPSOs and BPGs and clinical guidelines.
Yes.
On May 6th will be the next webinar. I believe that webinar will focus on champions, probably more in depth. It could be that it will be actually a workshop on champions for if you want to start to send some people. And elements that we have heard from even the previous webinar that people wanted to do more. If you have an area specifically that you were very intrigued by or that you would like to hear more in depth, do give us the ideas, because we will be having a webinar on this topic of clinical guidelines once a month, and we will tailor those to the needs of those that attend. For those of you, if any of you are attending the International Council of Nurses in Australia, please note that we will be having a meeting there on May 23rd, and that meeting will bring together all the Canadian BPSOs that we already have and the international one. I think that my colleagues mentioned to you that we have 68 BPSOs that represent 298 sites. A few of those sites will be in Australia, and we will be having a meeting, but the meeting will be open also for non-BPSOs, so that people can learn more and ask questions and engage in the magnificent journey if they so choose. So with that, I want to thank you on behalf of all my colleagues, and especially to you, Karen, that brought from the field actually reality of implementation and the tremendous work that you have done. And for any others around the phone that I know that you may not be a BPSO, but you have implemented guidelines, because we hear that all the time. Would encourage you to become formally part of the process. It's a hard work, but it doesn't cost money, and it produces amazing results for patients and for your communities, and also positions healthcare professionals in a very different way. So thank you very much, and have a terrific day. Bye.